In a world of EMS podcasts, EMS Office Hours is the only live podcast for EMTs and paramedics, transmitting the latest EMS news, trends, and topics. Turn down your scanners and turn up your speakers to join Jim Hoffman, Josh Knapp, and Dave Brenner in their latest podcasting journey.
So, welcome to EMS Office Hours. I'm Jim Hoffman.
And I'm Dave Brenner.
And Josh, a little preoccupied today, so wasn't able to make it with us on the live show, but I'm sure we'll get him next time, Dave.
I'm sure.
Yeah. So, a little bit of a short notice, too, for the listeners. I wasn't able to get this out that quick enough to get a lot of people to join. It was funny, at last episode, I know you had mentioned we got some interesting feedback and people enjoying the show, and I actually got some stuff from YouTube as well, people on YouTube who wanted to jump in and join the chat. So, I said, you can always, chat after the fact. I always read the comments even after the show as well. And, people can chat during it. We live stream it to YouTube and to Facebook. So you can kind of chat either way. And if I don't see the comment for some reason, I usually see it after the show and go ahead and, reply to anything that you say there. Just one housekeeping thing I want to mention, Dave, before we go in. Over at turbomedic.com, I just want to let listeners know I am looking for educators or contributors to come on the site with me. Just, maybe one piece of content every month or every other month. Could be written, could be a video of a talking head thing. It could be a quick little recorded presentation. Whatever the case may be, I have a list of topics and just short, video, nothing longer than 20, 30 minutes tops. But I have topics where you can break it down to even 10-minute segments. And, of course, I am offering some extravagant monetary compensation for people's time. So I have a few people that are working on stuff for me now, but always looking to give as many people opportunity as I can that want to get out there. Maybe they're a presenter someplace and they want to test out a new topic and they want to, record it. It's a great way to get the topic out there, kind of fine tune it and let other people see it maybe before you go live at a symposium somewhere or at an event someplace. So just FYI on that. If you're interested, you can just private message me, direct message me, and I'll get back to you with some details on that. So with that said, I'm just getting over the COVID, Dave.
Oh my gosh.
Yeah, it's been over 3 weeks. So I want to tell a quick story before we get into today's main thing. I had the COVID, tested positive and tested negative, but I just couldn't get rid of this cough. Doctor called in some cough medicine, didn't do anything. Then he called in Z-Pack, and that didn't do shit. So I said, you know what? I have a history of bronchitis. Let me go to the doctor and just make sure nothing major's going on. Just go to the doctor. And I don't know what the fuck's going on nowadays. Didn't take my temperature when I was there. I tell him what's going on in my lungs. He orders like a chest X-ray, and then he goes, "But you got COVID, so you just you gotta ride it out." I said, "All right, well that makes sense. I'll wait for the chest X-ray. I'm not coughing anything up, really. I got a little in the morning. I got to really work at it to get it up, but other than that, that's really it." Doesn't even listen to my lung sounds. He actually says to me, "I'm not going to come near you because I don't want to get COVID."
Nice.
But I had a mask on. He had a mask on. I thought, saying, what if we did that in the field with patients? We talked about this in the past couple of shows, right? About not giving patient care for whatever reason, withholding, delaying, kind of putzing around on scene. And you got people getting fired and suspended and all this shit. And this guy's like, he's the doctor. I'm like, I just started thinking like, what am I paying this guy for? I could have just could have called in he gave me steroids. You could have called that in. I didn't have to go to the office and sit there with a mask on.
You can't bill the same if you just do that.
What's that?
You can't bill the same.
Yeah, I know. Can't get my $15 copay.
I'll bet you it had a full set of vital signs, though.
Well, the nurse took a blood pressure and a pulse ox.
The sacrificial lamb.
Yeah. But
the canary.
That was it. There was no come up on the table, let me listen to your lungs, let me listen to none of that. Let me look in your ears and your nose, see if you got some inflammation in your nasal cavity, nothing. So
I hope you feel
I
better.
walked out of there like, I gotta change doctors, I think.
Sounds right to me.
I wasn't very pleased with that. But I just thought it interesting. I just wonder, like a lot of times when we out there on the ambulance, if we ever went a day, I'm not coming near you because I don't want to get what you have.
Well, we actually had protocols that included telling people to meet us at the door. So we didn't have to go in their house.
Well,
it wasn't a terrible idea.
Might come in handy.
And then we would put them on the trailer hitch to the back of the ambulance. No,
with the horses.
Mm.
Yeah. So, anyone in the chat, you want to make comments, you want to post something, please feel free to do that. But anything that we might be talking about today. What I wanted to talk about, Dave.
I'm back.
Dave is back. Dave, what I thought would be interesting, because I post a lot of stuff on social about preparing for exams and getting ready for tests and how to study, more effectively and all. But some of the comments that I've been getting, there's one comment in particular where the person has suggested that maybe we need to get away from having to memorize so much content in a textbook to take a test. Like, why are we doing more sort of, and this is like for final exams and national registry, why are we doing more open book type, testing where we can use a certain amount of resources that are available to us with, when you're taking the written exam and even the practical exam for that matter. I know I worked at a place where you took the practical exam and you were allowed to use your protocol book, keep your protocol book open to look up dosages and medications that would apply for whatever patient you were treating. Now, of course, if you messed up and you work under the wrong protocol, you probably fail the entire station, but that was one of the options. You can use your phone to use a calculator to do drug calculations, like all the things you would do in the field. So many times, I would see people take practical skills and they do get like a med math calculation, and they start doing the lidocaine clock and the dopamine this, and it's like they're trying to memorize, okay, every 15, and it's like, wait a minute, if you were in the field, you would take out your phone and use your calculator, or take out a notepad and start jotting down, calculations. So I think there's some merit in that, in doing open book stuff like that. But I do think that there has to be a certain amount of studying involved and being able to recall information and apply it, as a clinician. Even doctors use, reference tools and reference manuals and stuff like that. But I think it is important, though, that we have to be able to recognize signs and symptoms and be a clinician and be able to critically think in the field and how to apply this type of stuff. I know that I think the National Registry, when you take the test there, you can bring a blank piece of paper in with you to take the exam. And one thing I always suggest for people to do is to write down some key things when you first sit down. So you always it's almost like a cheat sheet. You're writing down, some mnemonics and some, so acronyms and stuff like that to kind of help you stay on track when you're looking at questions and patient care scenarios and stuff like that. So I'm just wondering, Dave, what's your take on that? I know, you're involved in some education programming and stuff. And do you think it would be beneficial for the students to kind of going into the class, right? Especially, let's say EMTs, they're going into the class, but in the back of their mind, they know, well, I don't got to study that hard because at the end, I can use, a review guide.
A resource.
Yeah.
Call a friend.
Right. I'm going to phone a friend. Final
Lifeline.
answer.
I'm going to call and send I'll ask the audience. Stick my head out the window. What do you guys think?
50-50. And it's never the 50% that you thought it was to begin with. So then you're stuck with the other two choices that you didn't even think were the answers. That sounds like the National Registry. Anyway, doing that.
Yeah, I think it's complicated. I think we all need a really sound foundation in emergency care that we should be able to call upon on our own, to rest everything else on. I think there are some things, and medication dosages certainly apply, that we not only ought to be able to look up, we shouldn't be so cocky as to not look them up. That's what I'm thinking.
That's a good point.
The killer, of course, is pediatric with epidoses, and people get out of their minds. How much is this going? Is it 1 in 1,000, 1 in 10,000?
How do I make the 1 to 100,000?
How do I draw it up? What about the epi drip? So don't be so cocky as to believe you can't make a mistake. People make mistakes. Doctors make mistakes. They make mistakes in hospitals. You read about people blinded because somebody put the wrong potassium percentage in their eyes, and now they're blind for life. People, we are people. We are humans, and we do make mistakes. And I was always astounded growing up how, like, I go to the doctor, I'm sick, the doctor would examine me. I'm not talking about when I was real little, because I didn't catch any of this. But as I got older, and the doctor would say, in the examination room, all right, get dressed, meet me in my office. I get dressed. They sit down, they talk to me. They say, this is what I think you have. You need 375 milligrams of Augmentin 3 times a day. Take it with milk, take it with food, take it on an empty stomach. And I'm saying, this is impressive. And of course, they went down and they sat with the PDR, which is the good news. It was the good news. They sat down with the PDR and they looked at it and they said, yeah, this is the right thing. But they also need to know the right thing. They also need to know when they're in the right. I have a colleague who, using ESO is very interesting, like when you're entering medications. Mm-hmm. So I know a person who repeatedly, and I've spoken to them about it. I said, I'm looking at what you got here. You got a patient with hypertension, and you're recording that they're taking metaproterenol. Well, they say, it pops right up when I start typing. I said, yeah, a lot of things start up when you start typing, but metaproterenol is exactly the opposite drug of metoprolol, which is what they are taking.
Right.
They're not taking, I don't remember the last time I knew anybody taking metaproterenol, which was, used for asthmatics, and COPD is to open up their passageways. You got to know that, that what you're looking at is the right thing. People make mistakes.
That's a good point. That's a good point, because if you don't know a lot of the basics with that, no amount of computer help or review guides or apps or whatever is going to be beneficial to you.
I just see there may come a day, I don't know, we're clearly not there yet. We get in, we say, Siri, my patient has an expiratory wheeze. They are perioral cyanosis, but interestingly, they just flew in on a plane. They're also on oral, birth control. And what are the rule outs, Siri?
Right.
Yeah, and you may get some. It would be interesting. When I don't think we're there yet, but I even want to.
We got the chat GPT coming up. You never know.
So I think it's a good idea to use references. I know that the docs, even this was something I was both surprised and enchanted with. The docs in the ER, as I became more familiar with the docs in the ER, I heard one of them say to them, he said, "Get me a T sheet," to somebody. He was going in to see a patient. He said, "Get me a T sheet." I'm thinking, what the heck is a T sheet? Is it, on the bed or what? So the person came in and handed him a piece of paper, and on the top it was a big bold T, and it was a trauma assessment. It was the things to look for on different parts. And I said, "You got these for other stuff?" He says, "Yeah, we got these for everything." He says, "You come in with respiratory. We got a respiratory assessment sheet. It tells us what to look for, tells us what tests to do." I said, that's pretty fabulous.
Do you think that they're doing that more for a liability thing, so they don't miss something? You had mentioned before about, you're getting too much potassium and someone goes blind. Like, they're doing it so that there's less of a chance of them making a mistake, or that there's accountability, so that if, like you said, they get the trauma sheet and they don't do an assessment on that trauma sheet, and then later on something happens, that they are held accountable because, hey, well, you filled out this trauma sheet and you said you checked for abdominal tenderness or whatever, but turns out the guy had a bleed going on that you didn't really find, so they'll hold that doctor accountable, and it's sort of
but is it worse to not look it up and leave it out? I mean,
no.
if one is a lie, that's always bad.
Yeah.
I mean, I don't recall whether or not they filled out the sheet or simply followed the sheet as they went along, sometimes making notes so that they could put them in the charts later. I don't know. I don't know that. I don't think they handed in the sheet. I think they had a sheet.
Yeah, more of like a documentation type thing.
It helped. I thought it was great. I thought it was great. And let me tell you, I am thrilled to be able to have my protocols not on a flip chart. I like before we had it on our phone, you were able to buy, ACLS is Us, and the PAL stuff and the New York City protocols. I bet you there were people putting them out on flip. I
did that. That's how I first started out. I mean, listen, I first started out.
You thought I said that by accident?
I made a 4-inch by 4-inch, pocket field guide, and it had all of the New York City paramedic protocols in there, common hospitals and specialty hospitals, stuff like that.
You condensed. You took their big book and you condensed it into the essential.
I condensed it. I took long words like epinephrine out, and I put epi and and stuff like that, because I felt sort of like what we just talked about, right? I felt that when I would make that guide and I would put in IV instead of intravenous, or epi instead of epinephrine, my thought process, well, you're a paramedic, you have your whatever, you should know that what these abbreviations are.
You just triggered something for me with the abbreviations. All right. And it's something that our medical director has jumped on. I've been jumping on it for years, but now with a new medical director who jumps on it, it actually has some punch. I am really disheartened when I used to look at patient assessments and the patient and the medic, EMT medic, they all were doing it, writing down that, I got a 46-year-old patient who was in an MVA, airbags deployed, restraints were worn, and the patient and my 46-year-old male has positive PMS. And I'm thinking, not a chance, not a chance that they got premenstrual syndrome. And our medical director has said very clearly, no more positive PMS, no more negative DCAP BTLS. Those are memory devices. They don't belong in a patient assessment. Use them, when you need to. You can write down absence of deformity, contusions. You want to write that down, go write. But, you're writing it to people who didn't have to memorize this stuff. But, I mean, there are clearly AVPU is AVPU.
Right.
CPR is CPR.
A lot of people with with that, I've had doctors the same way that hated, abbreviations, and
no, I love abbreviations. I just don't like being told.
Well, certain ones.
It's not that they're certain. They're memory devices. I mean, I could think of memory devices you wouldn't ever consider writing down.
Yeah. Listen, I think like I said, I think that that comes into play. I think it's a great resource to have at the ready. But I think if you're an EMS professional and you're an EMT or a paramedic, that you need to be responsible for a certain amount of
absolutely
of recall, a certain amount of knowing how to apply,
and even to turn to the
recognizing
right page.
Common signs and symptoms. You should say, "Oh, okay, what do you have?" And then start looking up on your book. Okay, you've got this, but you don't have that. What else? And and like you said, asking Siri, my patient's got these signs, but it doesn't have this.
Some of this stuff is happening in the big in the grown-up medical fields. There are charting. You start to do some charting on a patient, and you write down that they are tachypnic. You write down their age, and then you write down they're breathing 24 times a minute, and you take their temperature, and it's 100.4, and you start entering other information, the blood pressure or a white blood cell count, and it, all of a sudden, a sepsis rule out, lights up. In other words, the computer did it. You started hitting those things, and it lights up. And it wouldn't be terrible if we had stuff to guide us along there. We've had people.
Yeah, I remember when sepsis first started getting attention. In EMS,
they've been teaching it forever, but it started getting attention lately. Yes.
Yeah.
And I mean lately in the last couple of decades.
There's we had talked about this. I can't think of the top of my head, but the score that you would have, blood pressure versus heart rate versus mental status. What level sepsis alert?
QSOFA or SIRS?
Yeah. What level of sepsis alert the patient would get? And I would say to myself, well, sort of like you just said, if I have the tablet and I'm typing in this information, that something should come up on the tablet to say to myself, well, your patient's score is a 3, a 4, whatever the case, so that you can say, well, all right, the heart rate's one thing and the blood pressure is another, but I don't think it's sepsis. So you can kind of almost bypass what the computer's suggesting.
And you better have a good reason.
Right. But then again, like I said, but justifying that in your comments.
Right. Their altered mental status, but their blood sugar is 34. Wait till I correct that, and then I'll look at the altered mental status.
Exactly. Stuff like that. So I think it really, listen, I think that everything that we're talking about today, they're all tools that we can use, in the field. And I think that a lot of them we should be able to use when we're taking exams. The whole thing of train like you fight type thing.
Practice the way you play it.
What's that?
They used to say, practice the way you're going to play it.
Yeah. So I think it is important because when you're out in the field, at some point, like you said, like a pediatric patient, let's say, at some point, you're not going to sit there staring at the patient, trying to remember a dosage or trying to remember, a vital sign value that might be lower or higher for that age range, let's say. So having a quick resource to look it up, to almost verify what you're thinking, or to trigger a memory for you to say, oh, that's what it is. You know what I mean? I think I think it's a good idea. And I think, it has merit to start trying to think of letting students test that way. But like everything else, I think there's a lot of,
I think some foundational things
obstacles that could get in the way if you're not careful.
People need good foundations. That phrase in almost every protocol book at the end of the general direction is
right.
But good clinical judgment.
Good clinical judgment. Yeah.
Yeah.
Yeah. Oh yeah.
You gotta have that.
But at the same time, right? The protocol always says, most protocols tell you too, that if when in doubt, contact medical control for guidance, right? So it's almost, so in that instance, your memory tool or whatever goes to medical control, But then on the same side, you'll get a doc who will ask you questions to see if you know what the hell you're talking about. When you're calling a doc to ask, hey doc, I'm not sure what's going on with this patient. And if you don't have all the right signs and symptoms and history, or like you said, medications that a patient might be taking that can point you in a direction of where you need to go for that patient, it doesn't help you, it doesn't help the patient. So I wonder, like you said, foundation, should it be a certain amount of school up until you're allowed to use those type of resources?
Maybe that doesn't sound terrible.
Or just use it towards the very end.
Well, what resource, it depends upon what resources. The resources to figure out what the condition is?
No, I think
I think we should be able to do that.
Yeah.
But that doesn't mean we shouldn't have reminders built in. But when you're taking a test, I think taking a test, what we want to do is see if they have clinical judgment. And we don't have a book on clinical judgment, that you can look up good clinical judgment.
You should write that, Dave.
I should write that.
You should write a book about how to have good clinical judgment.
Oh, yeah. That's a good idea. Clinical judgment.
Yeah,
and everybody spends, you can't go to a conference where somebody's not teaching about, improving clinical judgment, critical thinking.
Yeah.
All of that stuff.
Yeah.
You can't go there.
It's a new sepsis. Critical thinking.
You're lobbing the ball at me, right?
Yeah. No, like I said, I think it has merit. I think that
I just wanted to throw something in. I have two instances in my head. The first time I had to do a dopamine drip. All right. Now I'm going to tell you, that math is my specialty.
Mm-hmm.
And I've taught the dopamine drip. You've put out my dopamine drip.
I have it on the website. Yes.
Right. And so the first time I had to do a dopamine drip, I looked at it. I looked at the patient. I did my pounds to kilograms conversion. I did all of that stuff, and I came up with the drip rate. And I called medical control, and I said to them, "Listen, I got this patient. They need dopamine." And they said, "Why is that?" And I told them. They said, "You're right." I said, "So this is how much they weigh. I just want to confirm my dopamine drip rate, okay?" And they put me on hold. So when I was pulling up at the hospital, they said, "We almost got it." I said, "Too late. I'm at the hospital. I'm already there. I was confirming it with you." And it was after that that one of the docs said, "I'm just going to put a spreadsheet up there. You put in their weight, and boom, and there it was." And the other time I did it was when I was treating my granddaughter who was in status epilepticus. And I was, I had to give rectal Valium, and it wasn't the mistake I could afford to make. So I called up medical control. I said, "Listen," I said, "this is my granddaughter I'm treating. I just want to make sure everything is just right. I may not be in the best frame of mind." And they were good with it. They confirmed what we did. I got to tell you, they got stressed out. They were stressed out because they were helping me with my granddaughter. And if they were stressed out sitting at a console, you have no idea what it was like in the back of the ambulance with my granddaughter, with my daughter and my son-in-law in the back, and we were all crying. It was hard.
Sure.
It brutalized the EMT who was there with me, and we all got PTSD from it, and except for my granddaughter, who is, by the way, is fine. All is good with her. She's wonderful, and that was about 9 years ago. But there are times to call medical control. If you think that things like that don't get in your head, they don't need to be related to you. I mean, pediatric calls can get in your head right away. All you got to do is, usually there's a parent there,
Yeah.
All you got to do is relate to anything on scene, and it could be tough. Kudos to those who can do that all the time. I wouldn't do this all the time.
Yeah.
You're not going to find me in a NICU or a PICU ambulance transport unit. I'll do it from time to time. I can't do it every day.
And again, pediatrics is one of those things you can easily refer to where you tend to need some sort of reminding type thing, Brothel tape and whatnot. And I remember having a fire, fire in Brooklyn one time, and we had a couple of pediatric patients we pulled out of there, and they were all in, cardiac arrest and respiratory arrest, and the hospital was getting more pediatrics at once than they wanted. But I remember the doctor being very flustered when we brought the patient in, so much so that I went behind the doctor to tell her, this is the dosage, this is, the size airway, this is whatever, so that she could get going, because she's yelling for Brothel tape and everybody else is running around like chickens with their head cut off, and nobody's like focused. But I had the benefit that I was already past the franticness of being in the back of the ambulance and suctioning and airway and getting in an IO and all that stuff. So by the time I got to the hospital, I was kind of over that stress point. You know what I mean? So I think that's something where as providers we can come in handy in an ER environment too, or even when you back up another unit and they're having a hard time because of whatever the case. Maybe it's a pediatric, maybe it's multiple patients, but then you come in as that secondary unit, you're, I think, going to be much calmer and be able to approach it a little bit with a clearer head than the people that are kind of immersed in it and trying to work through all the stuff that's getting thrown at them before you even got there.
I would say definitely maybe.
Yeah.
Definitely maybe. Oh my gosh.
Yeah.
It depends. It's
I mean, listen, there were times where I had multiple patients and it was getting overwhelming, and when another unit got there, even though I was technically still, in command or whatever, just knowing there was another unit there was able to,
it's a relief.
Yeah, it helped me think a little clearer. So whether the resources, I think, are an app or a field guide or another unit or calling medical control, I think we need to use them, actively when we're, treating patients. But I also think, like you said before, I think that it's valuable to consider using certain elements of that when we're taking exams, So I guess we can end it there, Dave. I don't want to go on too much, about the same thing over and over again. But I thought it was just kind of important because, like I said, one of the listeners had made a comment about that on one of the Facebook pages, and I thought it was key to just kind of bring it up. I thought it was a valid suggestion, and I've heard that before over the years. And like I said, I've been in situations where certain agencies will let you use certain things and when you take an exam. So
they have to be useful and rapid. You can't start learning.
Right, exactly. Well, that's what we just said, right? You have to have a certain amount of recall when you're on scene, for patients, and any tools and resources that you use just have to be something that's a quick reminder or something to trigger your memory. And I think that's when we talk about testing. I think that's what you have to kind of get down is figuring out, okay, we can let students use something to help them on a test, but it's got to be limited in a way that it's more of a memory trigger than, let's open the book to pneumothorax and see all the signs and symptoms and treatment.
And you're not going to Google, how do I start an IV?
Right. You got to start an IV. Step 1, introduce yourself to the patient.
Did you go to school in New York? High school? Did you go to high? So I don't know if you did. When I went, and I know I went well before you, and I took chemistry and physics, and on the chemistry and physics regents, they gave you they gave you resource sheets. You didn't have to memorize the periodic table. Of course, back then there were only 16 elements, but that we knew about. But no, they gave you the periodic table. They gave you a whole list of formulas in physics. But if you didn't know when to use them, and it's pretty much like that.
It's funny what you said before too, with the doctor making the spreadsheet with dopamine dosages on it. You know, how many ambulances have that posted up in the back of the ambulance? You know,
I hope that they at least have it in somewhere, in some sort of.
I used to get frustrated when it would be up on the wall in the back of the truck.
Oh, just divide it by 6.
It would be the lidocaine, the dopamine would be there, epinephrine would be there. You know,
divide their weight by 6. That's the drip rate. Just do it.
Yeah, but I was always like, why don't we just have the same thing that's in the truck laminated inside the drug bag?
Yeah.
Because if I'm in the house, I'm not running out to the truck to get a quick cheat on.
Or if you've got a pre-mixed dopamine bag, why not just have a sheet of paper in there attached to it, that has the drip rates?
Yeah.
Patients' weights start here, go to there.
I think sometimes we make things too hard on ourselves.
Yeah, we do.
We don't think we don't make things as easy as we could. You know,
you know what? To some degree, I think it's like hazing. No, I'm serious. You know, things have come along to make things better, but still, I got to show you how to use a D-ring for a traction splint. No, you don't. No, you don't. We got this great stuff now. You don't have to do that. And
right.
And let's make everybody lift everybody off the ground. No,
right.
No, we got stuff for that.
That's true. All right, Dave. Anything else you want to touch on, or anything you want to talk about?
I'm just going to mention this. I just got invited to go to the Metro Atlanta EMS conference in April. So I'm going to be presenting there. I'm very excited. I have never been there. I think I might have been on a plane that stopped there once and went on, but I've never been there. I'm looking forward to being in Atlanta and to meeting people there. I love meeting EMS folk from all over the place.
Yeah.
We're all the same in the exhibit hall. Everybody's walking around the exhibit hall with bags and stuff in there. But more importantly, I love talking to them.
Yeah. So. All right. Well, guys, we had a few listeners today that joined us live. I appreciate you guys jumping in here and listening live. Again, any comments for us, be sure to put them in the notes. I always read the comments, even if it's days later. I'm always checking out comments and trying to reply as much as I can. And like I said, don't forget with turbomedic.com, I am looking for some educators and whatnot to join me there and just give either a quick written training document or a video or even an audio. But I can explain it all to you if you're interested. Just go ahead and let me know, PM me or direct message me, and I will go ahead and give you details on that. All right, Dave, that's it.
I'm back just in time, huh?
Yeah, just in time.
It was good today. I enjoyed it.
Yeah, I thought so. Without Josh, don't tell him though.
Oh, I miss Josh.
Or hurt his feelings. I don't think he got back to me with anything. No, he didn't get back to me. Oh, he did. Oh my God. Okay.
Later.
All right.
Later.
All right, everyone. That's it. As always, I am Jim Hoffman.
And I'm Dave Brenner.
Stay.